Good morning, everybody.
Good morning.
Again, good morning, everybody.
Good morning.
Awesome. Thank you. I want to welcome you all to a MS Views and News educational program. We are doing these events now in 27 states. I know we were here, I think, for our first time in Cincinnati was about 5 years ago, and at that time we were only doing programs in 5 states. But again, we are now doing this in 27 states, and we are very heavily this year reaching places in true rural America. For today's program, we want to thank 2 of the pharmaceutical companies that supported us to be able to do this program today, and that is Celgene and Novartis, and I hope that you all can thank them as well. Hoo-hoo, give them a rah-rah, go. Thank you. Thank you, thank you. All right, today's program, we have Dr. Gary Owens from Delaware, and then we have Dr. Aaron Boster. Now, each of them are going to give 45 or 50-minute presentations, and then we'll open up to Q&A. All right, so let me get into introducing Dr. Owens. He's Gary Owens. He's an MD, primary care physician by background, former vice chair of Department of Family Medicine at the Medical Center of Delaware. He's a former VP of Medical Management and Policy at Independence Blue Cross. He's authored over 125 publications, including a dozen on economic and payer management and MS treatments. He's interested in the management and funding of treatments for multiple sclerosis. He has 2 close family members with multiple sclerosis, so he can understand the issues from both the individual patient and the population perspective. Let's welcome Dr. Gary Owens. Thank you.
I know I got to run. Thank you, Stuart. Well, good morning, everybody. Again, thank you so much for that kind introduction, Stuart, and it's great to see a nice sea of faces out there all sharing a common interest. And as Stuart noted, I come from the relatively small state of Delaware. There are probably at least a couple of cities in Ohio that have more people than we do in Delaware, because there aren't even 1 million people. Yet I ran into somebody here who actually knows my little hometown of Bethany Beach, Delaware. So small world department. And Stuart, you talked about running. We were just recently in the very far north near an island called Svalbard, where polar bears still are present. And my wife said, what are we going to do if we see a polar bear? And I said, it's very simple, we run. As many of you might have noticed, I don't have the most perfect gait because I don't have MS, but I do have some orthopedic issues that slow me down. And she said, well, you can't outrun a polar bear. And I said, of course I can't, but I'm hoping to outrun you. So anyway, what I hope to do today is kind of rip the Band-Aid off a little bit about how healthcare services are provided. Just a quick, just a quick overview of what we're going to do. I'm not going to read this slavishly because, we'll go through all of this. But what my goal is really to somewhat demystify some of the issues that you may face when you're getting insurance coverage, drug coverage, dealing with specialty pharmacies, hearing terms that you may never have heard before, but you've had to learn very quickly. So just a quick show of hands. How many people think they completely understand the funding and insurance principles for the management of multiple sclerosis? I won't even raise my hand on that one because, as you'll see in just a moment, it can get quite confusing. And as Stuart said, I do have a personal as well as a professional interest in this. And the personal interest is I had 2 close family members with MS, one a niece who is in a very different phase of her disease from the other family member, having had it now 25 plus years, and a son who was just diagnosed 3 years ago. And that's the real personal story. If you think about it, I worked for the Blue Cross system for 25 years. I ran their pharmacy department. I ran their medical management department. I was up to my neck in insurance benefits. Yet when my son got his first prescription from his MS specialist, he faced a bewildering array of things that he had to go through, some of which I even had to go back and sit down and rethink, okay, how do we handle this and how do I advise him on what to do best? And again, show of hands, how many people can relate to that story? Yep, quite a few of you out there. So it can be quite confusing. And ultimately, everything worked out well for him. He got the right medicine. He's now 3 years, and, has learned to deal very well with the system. But, in terms of MS, when you get a new prescription, it should be a decision that you and your doctor share, right? That what we do know about MS is there are lots of treatment options. Way back when I first started my work at Blue Cross, there was one treatment option. I'm old enough and have been in the business long enough to remember the introduction of the beta interferons for the treatment of MS. And we at the insurance company were agonizing, how in the world are we ever going to be able to pay for this very expensive medicine? Maybe cost $8,000 a year back then, right? I know you're all sitting down because now you can relate, many of your medicines cost that much per month. And as it turned out, it was a non-issue because when the medicine first came out, there really, there was a shortage actually, and people got the medication under a lottery system until the production capacity was able to keep up. Now we have 14 or 15 options. Some of those options need to be tailored to your stage of disease or the aggressiveness of the disease. And in addition to that, there are other things that come into consideration. Do I have insurance coverage for the treatment option that's being recommended? If I don't, what do I do next? All of those things come into play. So really the treatment choice becomes a shared decision between you and your doctor. What do I need? What can I afford? What will I likely have insurance coverage for? Are there alternatives if I have problems either getting this medicine or getting this medicine paid for? Those are all the things that my son faced when he got his first prescription. And so you think about getting a prescription when you go to the urgent care center or your family doctor, for some relatively minor condition. Maybe you have high blood pressure and you need a high blood pressure. You get the prescription, or the electronic medical record immediately sends it to your pharmacy of choice. And a few hours later, you walk into the corner drugstore, pay your copayment, and walk out with a prescription. Doesn't work like that. Usually for MS medicines does it. It's a lot more complex than that. And part of that's because of the cost of these medicines. There's a fair amount of management that goes on behind the scenes. I don't expect you to read this graphic. What I do point out here is if we look from 2012 to 2017, there is a relentless upward trend in the cost of medications to treat your disease. And you're all shaking your heads yes, so you're well aware of that. And because of that, there is a lot of microscopic focus by those who have to pay for these medications on managing this cost. And unlike a lot of categories of disease where there are drugs that are first choice, like you have in rheumatoid arthritis, for instance, and then you kind of escalate the treatment, in MS, there's often no specific first choice medication. So, it creates some issues that need to be dealt with. In addition to that, payers recognize that over a lifetime, because treatment of MS is a lifetime, and with the advances in treatment of MS, we are all hoping those lifetimes get longer and longer, right? They have. And in an analysis we did, and it's getting a little bit dated now because we published it in 2013 in the Journal of Managed Care Pharmacy, the total lifetime cost of a patient with MS is about $4.1 million. Now, I don't know about you, but I don't have $4.1 million of disposable money to pay for a therapy like that over a lifetime. We also know that just like every other disease out there, adherence to therapy in MS is difficult. Patients don't always take their medicines as stated. There's a number of reasons for those. You would think with a very serious and threatening disease like MS, everybody would take all their medicines. Well, it doesn't happen in any disease state, so don't feel like you're unique. For instance, we just did an analysis of this in advanced cancer patients and got very similar numbers in terms of people who discontinue their therapy when they're faced with a life-threatening. And so payers want to make sure if they're going to make this $4 million lifetime investment that the medications are taken. Now, I've just thrown out a lot of terms, right? specialty pharmacy, payer, and a number of other terms. And there's kind of a word salad out there that I want to try to clear up a little bit over the next few minutes and at least help you have some understanding. First of all, what's a payer? Well, it seems fairly obvious, but in healthcare, what a payer is that organization that handles the administrative and financial aspects. And in medicine, we have a very unique system, don't we? When you go to the grocery store and buy your groceries, you pick out your groceries, you go to the checkout counter, and you pay for what you have selected. So you have a very direct relationship as a consumer with the store. Think about healthcare. You go to your doctor generally, with some shared decision making, picks out the therapies and other treatments that you need given the best medical advice that he can. So you've already got one disconnect, that you're not necessarily selecting yourself what you need. And the second thing is that then goes to the pharmacy in the case of drugs, right? And the pharmacist is the dispenser of those drugs. You are the receiver of those drugs, but you don't pay for those drugs. So we've got lots of disconnects. It's not that one-to-one anymore. And therefore, the payer is the one that is kind of paying for those drugs, but they don't order the medicines and they don't consume them. So this triangular system gets quite complicated at times. And who are the biggest payers in the U.S. for healthcare? It's not you and I as individuals. Only about 10% of healthcare costs, the $3.5 trillion we spend in the U.S. On healthcare. Is paid for by us. Now, 10% of $3.5 trillion is a lot of money. I don't think any of us would cribble about $350 billion. But the biggest payers in the U.S. are actually us as taxpayers, right? Because Medicare, Medicaid, and other social programs are about 40 to 50% of the spending on healthcare in this country. So we as the taxpayers. The next biggest portion, the next 40% roughly, is paid for by employers. And again, we in this room actually pay for that because that's money that can't be dispensed in terms of wages to us. So in the end, yes, we're paying for 100% of healthcare, but about 90% of it is indirectly through the government or employers. Now, I also use the term benefit plan. What is a benefit plan? Actually, a benefit plan is a contract. Each and every one of you who has health insurance coverage, and either whether it's Medicare, Medicaid, supplemental coverage, commercial insurance, OWAs, other weird arrangements, because there are a few of those out there, have a benefit plan, which is actually a contract. Now I'll ask for a show of hands. How many of you have actually read your benefit plan contract cover to cover? We have one. I haven't even read mine, so you're in the exception. It's just like buying car insurance or homeowners insurance. You only tend to read it when you need it or have a need. So, but the benefit plan's basically mandated by the Affordable Care Act, which created Obamacare quite a few years ago now, mandates 10 basic essential benefits be covered by health insurance plans, whether that's Medicare, Medicaid, or commercial insurance. And again, I'm not going to read all of these, but these are the 10 basic essential health benefits that we all have in our insurance coverage. But, and there's always a but to this, we don't have unlimited coverage. We don't have free coverage. I was already talking to a few people at the table I was sitting at, and people recognize that different benefit plans have very different out-of-pocket costs. And so you may be faced with things like copayments, coinsurances, deductibles, and benefit maximums. And now you're probably saying, well, what the heck are all these things and why do I even care? Well, let's start with a deductible. A deductible is what you pay before your health insurance benefits start. So if your deductible, say, is $1,000, you actually have to accumulate $1,000 worth of healthcare services before your insurance benefit begins to pay for services. So, it used to be that deductibles for health plan benefits were $100, $200, maybe even $500. Now we're seeing deductibles as high as $5,000 per individual. So they can be quite steep, and that first prescription you get can be quite a surprise if you're not prepared for the deductible. Well, what's a copayment and how does it differ from a coinsurance? A copayment is a fixed dollar amount. So your benefit plan may say, for drugs that are on coverage, your copayment is $10 for a generic, for example, $30 for a branded agent that's preferred, and $250 for a specialty drug. And I know I've thrown out some more terms there that we're going to get to in a minute. What is a coinsurance? A coinsurance is variable, meaning you're paying a percentage of the cost. So you may be paying 10% of the cost. So if something costs $100, you're going to be paying $10. But if it costs $1,000, you're going to be paying $100. And if it costs $5,000 at 10%, you're going to be paying $500. So co-payments, fixed in amount. You always know what they're going to be. Co-insurances, variable, based on usually a percentage. Now, some of those do have a maximum that you can spend, but that probably gets a little more complicated. Benefit maximum is a little bit different than that, because it means in some benefits, like medical equipment, for instance, many of you may have faced the fact that your insurance coverage hits a maximum, maybe $1,000, maybe $2,000, maybe $2,500, where above that, there is no more coverage. And all of these benefits, you can say, well, why the heck do we have those? And we have those because the actuaries have to figure out how to balance what you're going to have to pay, or your employer is going to have to pay, or the government's going to have to pay in premiums versus what they think you can afford in those premiums. So that's how all of that comes to be. So I just threw out some other terms that may be confusing to you. The first one is formulary, and formulary is nothing more than a list of drugs that have been reviewed by a panel of experts and are considered to be, in their judgment, essential drugs for the treatment, diagnosis, or prevention of illness. And there are several types of formularies, so it can get even confusing there. You can have a benefit plan that has an open formulary, which literally means all FDA-approved drugs, with some rare exceptions, usually drugs for lifestyle or cosmetics or those type of things, are covered, but they're covered with different co-payments or co-insurances. An open formulary with exclusion is just that, but your benefit plan will give you a list of drugs. These drugs are not covered by your benefit plan. And that's typically in categories where you have lots of drugs that work in the same way and have the same essential purpose, and the formulary may choose to only cover a portion of those. And a closed formulary, that's the one that's sometimes the most difficult to deal with, because in a closed formulary, the list of drugs are the ones that are covered. Anything that's not on that list are not covered, and the only way you can get that is through an appeals or an exception process. So just to recap that, open formulary, everything's available, but you may pay different amounts. Open with exclusions, basically everything is on there, but you may have to look and see if the drug you need or want is on the exclusion list. And closed formulary, very narrow boundaries in what drugs are covered and which ones aren't. So another term, how many of you have heard the term step therapy? Quite a few of you. How many of you have experienced the need to do step therapy? Again, quite a few of you. And step therapy is basically a practice of starting patients with a diagnosed disease on what is perceived to be, based on some expert analysis, of the most cost-effective and safest drug in the category. And the goal there, well-meaning, is really to try to manage cost to an effective amount. One of the problems is, especially in MS, there really aren't any good guidelines for step therapy, so it can create some problems and hazards and tripping points when you're trying to get your first prescription or a new prescription. Some examples of step therapy, in common diseases like diabetes and hypertension that many of us in this room may well have, because most of us just don't walk around with one condition. Especially as we get older, we tend to accumulate a few more infirmities. But in those common conditions, very often step therapy will require one to have used a generic drug in the category before using a branded. In a preferred step therapy, there may be a branded agent that is on the formulary that is preferred over a non-branded agent, and you will pay less out of pocket for that. And then there's some guideline-based step therapies. For instance, in disease state like diabetes, where the guidelines are much more what should I say, specific, and they're specific because there's a large body of scientific evidence of what drugs are most effective. The American Diabetes Association for people with type 2, that is the older, the adult age onset, typically diabetes, metformin is typically the drug of first choice by the ADA, and then things change. So these are the kinds of step therapies that are out there. Everybody still with me? Hopefully I haven't thrown out too many terms too fast, right? Then you run into things like quantity limits. Well, what are quantity limits? Quantity limits are exactly that. Your benefit plan may tell you exactly how much drug you can get for over a period of time. So most benefit plans will limit your day's supply, that is the amount of drug you can get, to either a 1 month or a 3 month supply. Sometimes it can be more rigid than that. For instance, in antibiotics, where it may actually be not in your best interest if you have an acute infection to take antibiotics for more than 10 days to 2 weeks, there may be a quantity limit placed on an antibiotic of 2 weeks. And now more and more, because of the opioid crisis we're facing in this country, they're placing quantity limits on opioid medications to prevent abuse and diversion. And gee, why do you say, well, why do we have quantity limits? Well, some of it is because we already talked about adherence. Some patients don't take their medicine, yet they may fill it every month. And you go in, I know both my parents took a couple of medications, and when I had to clean out their house after my mother died, she still had probably a 6-month supply of my father's medications, who had, just because they would fill their prescriptions religiously, but not necessarily take them every day. So things accumulated over and over again. The other reason is, think about it, if you're very clever and you're about to lose your insurance coverage, you could theoretically on December 31st, if you're going to run out of coverage on January 1st, go and get a whole year's supply of medication, and that insurance carrier would be paying, or your employer or the government would be paying for a year's worth of medicine on your behalf when you no longer have coverage. So some of that is self-protecting to make sure there's not a little abuse of the system. Prior authorization, the term all of you have come to understand what that is. That's Mother May I, isn't it? It's basically your doctor has to justify to the payer, that is that organization that does all this administrative stuff, that the medication that he or she has prescribed on your benefit is the most appropriate one. Now, if it meets with the payer's guidelines and formularies, it's basically a slam dunk. It just goes right through the system. If it doesn't, as you probably already know, it can take a good bit of time to sort that out. So that's what prior authorization. And in this case, it really requires your prescriber, your physician, to have to submit medical information on your behalf to get the drug approved. Why even do prior authorizations? There are a number of reasons, and I know they all seem like a hassle, but these are not done generally to create barriers to care. They're done with well-meaning, but sometimes create difficulties. The first one is to try to avoid inappropriate drug use. For instance, let's use that example outside of MS of diabetes. If you're newly diagnosed with type 2 diabetes, metformin is the most appropriate drug. If you attempt to prescribe a third or fourth line therapy, that's really not appropriate in that setting. They won't be nearly as effective and may have more adverse effects. So that's one reason. It's, that's tied in with evidence-based use of the drugs. That is, what does the evidence say should be the best drug in this situation? It's also to promote some efficiency. If a less expensive drug will work just as well, or perhaps even better, than a more expensive drug, why wouldn't we all want to be prudent consumers and do that? And the end game is, no need to hide the elephant in the room. It's to try to best manage medical costs as much as possible. Now, you say, well, gee, why do that? Well, ultimately, as medical costs go up, all of us are affected, right? Because if you remember all the way back to the beginning of the talk, medical care is paid for by a third party, and those third parties are government, employers, and us, but ultimately who's funding all the rest of that? It is basically us. So it's generally done to manage medical cost trends so that the us doesn't have to pay any more than we have to. Okay, so I've talked about a lot of terms, and I'm going to stop throwing terms at you here. I'm going to catch my breath for a second. because the next thing, and many of you have faced this, whether you're newly diagnosed or have had your disease for a long period of time, and that is, I've got my prescription or my new prescription, what happens next? Well, the thing that probably doesn't happen next is that you walk into your drugstore, Walgreens, CVS, your local independent pharmacist, and hand them the prescription. They hand you back a sack of medication and say, that'll be $10, please, right? That's the dream sequence. That just doesn't happen. Because the current treatments are specialty drugs, right? They're generally handled differently, and there's a whole bunch of behind-the-scenes things that I'm going to hope to in the next few minutes. So peel back so you know what's happening behind the scenes. And again, I used another term, right? Specialty drugs. Okay, gee, isn't a drug a drug? Well, yes, it is. But specialty drugs are generally high cost, complex, used to treat chronic, complex diseases. Rheumatoid arthritis, MS, and cancer are some of the examples, but there are many, many more genetic diseases, those sorts of things. And so specialty drugs fall into that category of requiring more management. What is a specialty pharmacy? That is an entity that has arisen in the last 20 to 25 years to manage these specialty drugs and to manage patients with these complex diseases. So the advent of these newer drugs has created a whole new medical industry, that is the industry of specialty pharmacy. So what happens before I get my prescription? Well, most likely if it's an MS drug and you are covered by a third party, such as an insurance carrier, it's going to require a prior authorization. So your doctor is going to have to submit the documentation. The payer will evaluate that request, and in some cases, the payer may go back to the physician for additional information. Ultimately, the drug will either be approved or not approved based on the prior authorization criteria. And then, even if it's approved, it may be bumped up against the formulary to decide how much money you're going to have to pay out of pocket to get the drug. So, you know, all of these things come into play even before your prescription is filled. What happens next? Most likely, your doctor then sends that approved prescription, or your health plan sends that approved prescription onto a specialty pharmacy. The specialty pharmacy then processes that request, verifies that you do indeed have coverage for the drug, verifies how much you're going to have to pay, and you know what the next step is, right? You get a communication from your specialty pharmacy. Your copayment, coinsurance, or out-of-pocket cost is going to be X, right? Could I please have your American Express, MasterCard, Visa, or form of payment, because we have to have that form of payment before you will get the drug shipped to you. And how many have experienced that call from the specialty pharmacy? I would think virtually everybody in the room. And you may be contacted by a number of other people. For instance, if you have an MS specialist or in an MS center, they may have a nurse coordinator who's handling all this, and that nurse coordinator will contact you to make sure everything is working appropriately, right? You may be contacted by somebody in your provider's office or at the specialty pharmacy, you know, with offers of financial assistance if you qualify for that. So you may get a co-payment foundation contacting you. You may get the manufacturer contacting you. You may get something called an RX hub contacting you. All of those are designed to help you get your drug. And then you may even hear from your health plan who has a case manager or your MS center. That was one of my son's big issues. He goes, Dad, I got my prescription. My doctor got it all approved. I heard from the specialty pharmacy. I know how much I'm going to pay, but I got 6 phone calls over the next 24 hours, each from people, you know, trying to be helpful. Which one do I listen to? And it can be very confusing. We're not terribly coordinated there. So no wonder he was confused, and in some cases I was confused about who to listen to. The end of the story for him was he got his appropriate medication. He's been on it now 3 years. He is one of those people who has a little bit of OCD like his father, which may be a good thing because I don't know that he's ever missed a dose, and he travels a good bit for his work. And he has been in a state of no evidence of active disease since his original diagnosis. And cross our fingers, he just had his repeat MRIs yesterday, so we're waiting for those. So that's my story, and I'm sticking to it. Don't worry, just a couple more slides. I've probably given you more information. There are some timelines out there, right? Basically, while it seems like an eternity sometimes to get that medication, by regulation, payers are required to turn around complete authorization requests in 72 hours and urgent requests in 24 hours. Now, there aren't too many maintenance MS drugs that are urgent. Certainly, if you're in a relapse and need medication for your relapse, that's urgent, but so most of the time. However, a number of requests that go in for prior authorization are incomplete. They don't have all the information, and then it can take up to 30 days of back and forth between your physician and the health plan to get that information. Once the specialty pharmacy gets your drug, typically another 24 to 48 hours for them to process it and get your payment information and that sort of thing. And then they usually ship overnight to you, FedEx, UPS, some overnight type of process. But again, until your payment responsibility is met, that doesn't happen. So sometimes you can get your drug in probably best case scenario, 4 days to a week. Worst case scenario, it can be a month to 6 weeks. And that's just the reality. And please pardon the little cartoon there, but I couldn't resist putting that up there in today's world. So kind of summing it up, it is very true, isn't it? As I was saying to the group at my table earlier this morning, many of you probably know this, the commonest cause of bankruptcy for people over 65 in the United States now is medical related. Far and away, more than anything else for that. So getting an MS drug is not like getting your standard meds. It's a specialty drug, so it gets all these special processes that go on behind the scenes. Hopefully today I've ripped a little bit of that Band-Aid off so that you have at least an understanding of the terms, even if you don't have or don't need. I can guarantee you don't need to understand the inner workings of all that stuff. It may take some time, it may seem like an eternity, but do understand it's just not delays for the sake of delays. There's a lot going on behind the scenes. You will get contacted by a lot of people, and ultimately, most of you will learn to work your way through this very difficult and arcane system. But if you don't and you disagree, there is a standardized appeals process. You do have the right to file an appeal. That goes for Medicare, that goes for commercial insurance, that goes for Medicaid. It really goes for any third-party coverage. Those appeals are highly regulated and have specific timeframes. The caveat for you, this is where you do need to read your benefit plan or call your member services and that 800 number on the back of your insurance card, or look on the CMS website. There is a time limit for filing an appeal, and if you exceed that time limit, you may lose your right to file an appeal. Even the government is very rigid on that. So if you get a determination that you and your doctor disagree with, don't wait to file an appeal on that, or you could lose your rights. And then, even if you file an appeal and that appeal is not reversed, in all commercial insurance carriers, you have at least 2 or 3 levels of appeal. In Medicare, you have up to 5 levels of appeal all the way up through federal court. Not too many go to federal court, but there are a few. And they're all regulated by state and federal regulations. So with that, I would love to stop talking at you, right, and talk with you, if I might.
Hey, great. Let's give Doctor a round of applause, please. Who's got questions for the doctor? Somebody's got to start this. I know everybody's always afraid, but somebody's got to get, thank you. One brave soul.
There's always somebody who has to be first, okay. And you're the brave one. And yes, please, if you do have a question, wait for Stuart to get the microphone to you.
I'm always a little confused about coinsurance versus deductible. I have both on my health insurance policy. Yes. I assume that if you have paid part of your coinsurance or your coinsurance due, that goes towards your deductible.
Yes, it does.
So your coinsurance can kick in before your deductible is paid off. In other words, you're not waiting for coinsurance.
And again, that depends on how your benefit plan is written. Typically, your coinsurance in most plans will happen after your deductible is met. So you got to meet the deductible and then the coinsurance. But what the coinsurance then does is go into what's called your out-of-pocket maximum, because most plans have what's called an out-of-pocket maximum. I'll give you a good example. You may have an insurance plan with a $1,000 deductible, a 20% coinsurance, and a $5,000 out-of-pocket maximum. So the first $1,000 is yours. That goes towards your out-of-pocket maximum, so you've met $1,000, right? The co-insurance you pay, maybe that's $100. So now you pay that for a prescription, you've met $1,100. And then as you get other services for which you pay out of pocket, those all go to your out-of-pocket maximum. That's the more typical way it works. Now there's some hybrids of that that can work differently, but that's the typical way it works. Usually the deductible is the first thing that comes out of your pocket.
Okay, thank you.
Sure.
Okay, say you have had a relapse and there are medications to treat you instantaneously. So you don't have that kind of time to wait around and see, is your insurance going to cover it, or how are you going to pay for this? You need it immediately. So is there something to, some kind of insurance or something that will kick in for people who are in a relapse situation?
Yeah, the good news is for most relapses, the medications that are needed are not managed, and therefore they're the kinds that you can either arrange to get through an infusion service or oral medications at times, and most of those are not managed. There's one exception. There's one fairly expensive medication for relapses that is managed. I won't mention any names. And then the two options are, you can go through an expedited approval process, or your doctor can opt to switch to an alternative.
Right, next question's over here.
So I have a question about selecting the insurance. I mean, there are 42,000 different types of insurance, and you can talk to someone to say, this would work out best for you. Well, if that doesn't work, next year you just run your finger down the page and pick a next one. Well, how do you really pick what's going to be best for you?
That is probably the most difficult question that all of us ever face, because you're right, especially once you become a Medicare beneficiary, you now have a vast array of supplemental plans. Now, the first thing I'll tell you is, if you can afford it, everybody with MS should have a supplemental plan. That's just, a given. If you can't afford it, understood. But the cost can be astronomical. Once you really get down to deciding, which supplemental plan do I need, there's no magic, unfortunately. There's no one source you can go to. There's no great website. There are helpful websites. There are counseling services out there that's probably money well spent to help you do that. If you have an insurance broker, they may be able to help place you in the right benefit plan for you. Now, there'll be a little bit of cost to that, from your broker. Most of that's collected from the insurance carrier, not from you, so don't worry about that. Now, the downside to that, and I'm not demeaning insurance brokers, is they often tend to place people with the insurance coverage where they get the most from the insurance carrier. So there's a hazard, a bit of a moral hazard with that. Talking to other patients with MS, talking to your doctor, sometimes we'll have a financial counselor. I mean, there's no one best solution for that. But yes, you have identified one of the most difficult problems that people have to face, especially if you have chronic disease, and especially if you're on Medicare. Now, if you're employed, it's usually not a big decision, because your employer only usually offers one or two benefit plans. So, you can kind of put them side by side and pick the one that works best.
Next question here.
I'm not evading your answer, but there is no great answer.
I'm not on Medicare yet because I'm still employed. However, I am curious, does Medicare cover any of the MS drugs?
Well, the answer is yes, but under different benefit plans. Any MS drug that's infused, we'll use a drug like natalizumab, for instance, that's infused, is covered under Medicare Part B, B as in boy, okay? However, and there's a however, Medicare is an 80-20 plan, so you are responsible for 20% of the cost of that infused drug, unless you buy a supplemental plan, in which case then the supplemental plan. Now, let's say you're taking an oral or a self-injectable medication. Then you have to have a Medicare Part D, D as in dog coverage, to get coverage for that. So the answer is yes, but it depends on which one you're getting And that is your out-of-pocket cost, and your needs are highly dependent. If it's B, you need supplemental coverage. If it's D, you need Medicare drug coverage, or you can go into managed Medicare, Medicare Advantage, and it all rolls up into one.
Thank you very much. That was very helpful.
Next one's across the room. I can't run though.
You're getting your exercise.
Is there a maximum out-of-pocket that or prescription coverage that at one time they'll say, you've done it, you've been on your medication for 20 years, we're not going to pay for your MS medication anymore?
No. With the Affordable Care Act, the lifetime maximums were eliminated. Medicare never had lifetime maxes. Many commercial insurances had lifetime maxes between $1 and $5 million. As you can see here in that cost analysis, an MS patient could spend $4+ million over a lifetime. Those were all eliminated by the Affordable Care Act.
Next question's right here.
How effective is it to work with the MS one-to-one people to try to figure out how to get your medicines?
I think it's very effective. Very often, large MS centers will have financial and care coordinators that can help you with that and help you work and maybe even help you make the choice of your initial therapy or the therapy you change to based, in part of it, a big part of it has to be clinical, but if there are 2 or 3 clinical choices, there may be one that's more cost and financially effective for you. The RX hubs by the manufacturers are pretty good, and even the specialty pharmacies are pretty good at giving you information. Now, again, the downside, remember the slide where you might get calls from you might get conflicting information, and then the dilemma is which one do I believe? I would say in that one, if it's the medicine that's right for you, take the cheap. Yes, sir.
My question is, why do we find that MS medicine is much more expensive than a lot of the other drugs on the market for other diseases?
Wow. Yeah, that's a tough question. The short answer is that it's a relatively small population of patients, and the developers of these drugs, in order to justify, developing drugs for a small population, have charged higher and higher prices. Can I justify all of it? I don't know. I mean, it is high. I guess the only consolation is your disease is not alone. In that, I was just talking to the table, there's a new cancer drug that just came out in the last year for a very specific mutational subgroup of cancers that makes your drug look pale by comparison, $32,000 a month, right? Or the new CAR T therapy that you may have seen on the news for certain types of lymphoma and leukemia, $465,000 a year, right? Or a new drug for a rare pediatric disease called spinal muscle atrophy, which is a gene therapy at $2.1 million for one treatment. So I'm not justifying any of this. I'm just saying that's the world we live in.
Over here, please.
Do you know of any organizations that give grants to help pay for MS medication?
Yes, there are. They're what are called Copayment assistance foundations. They're registered with the federal government as 501c3 foundations, okay? They are highly regulated and monitored by the Office of Inspector General because the grants that they give can't be in any way be perceived as inducements to use a specific medication. The grants are usually means tested, which means that you have to have under a certain level of income to get the grant. The grants also are based on funding that they get typically from manufacturers, also some of it's from other public sources, so they can be quite limited. Organizations like Patient Access Network Foundation, National Organization of Rare Diseases. If you Google patient assistance foundations, you'll get a whole list of them. But they may not all have MS funds, and sometimes the MS funds run out of money fairly quickly. But again, a financial counselor at your specialty pharmacy or at your MS Center's office may be able to direct you to one that does have funds.
So for everybody that's taking notes on these different things that Dr. Owens is speaking about, remember though that you don't really have to, because this will be published in a couple of weeks, and everything that's been said, you can, you get that information again on our website, okay? All right.
First of all, I did want to thank you for coming here because there's some sensitive topics and you're opening yourself up to some tough questions.
No, they're not tough questions. They're the world we're in. It's the reality of the world. Medical care is costly, and there is a tension between those who must receive the care, those who must prescribe the care, and those who must pay. Remember the triangular system I talked about. It's not always healthy.
Only had one question,
Sure.
but I wanted to piggyback on what this gentleman asked. Since it was a relatively small number of people, with the study that the MS Society did that found that since the last study of the number of patients done back in, I think, 1975, it's now doubled what the number of MS patients are. Do you think the cost is going to go down since there's really more MS patients than we thought there were?
I'd like to be optimistic, and yeah, the number of MS patients, probably because we're much better at diagnosing MS now than, and I'll leave it up to Dr. Aaron to either confirm or refute that, because I'm not the clinician in MS.
The question that I had though was, after you had a personal experience with MS with your son, how did that impact you in the way you viewed the job you had done over the years?
I became, certainly more attuned to some of the impact on others. I was already aware of it from my niece who did it for 20 years. I guess I would have to say in health plans and payers and at CMS, while the perception is a lot of obstacles, there's a lot of very talented and dedicated people who are both medical and non-medical professionals who try to keep the health plan benefits as affordable as possible. Unfortunately, that tension sometimes rears its ugly head when you need something. So we all try to do our job to the best of our ability. It's just like you're generally very happy with a policeman who comes to your house when somebody's about to rob it. You're not as happy with that policeman when they pull you over for doing 35 and a 25, are you?
My question was about the formulary process.
Yes, ma'am.
Are there a lot of doctors, people in the medical field that are involved in deciding what drugs will be paid for?
Yeah, and the simple answer to that is yes. Every PBM, every health plan has what's called a P&T committee, a pharmacy and therapeutics committee. That committee is typically made up of pharmacists, both in the community as well as academic pharmacists. It's made up of physicians in the community and academic physicians. In certain areas, you have the ability to consult with specialty physicians. They're fairly complex clinical and economic analysis. Every drug that goes through a P&T committee typically has what's called a dossier. The dossier can run anywhere from 10 to 50 pages long based on the scientific evidence. Now, that being said, they also come with a 2-page executive summary because we know that a P&T committee member who has to make decisions on 5 drugs is probably not going to read 50 pages on 5 drugs to prepare, so they often read the executive summaries, and we usually have a doctorate of pharmacy present the information. So you try to do as much as you can to be evidence-based and guideline-based. In the end, there are also decisions made ultimately on cost and cost effectiveness as well. And so it does create some of that tension. But it's a very scientific and rigorous process. It's not a dartboard.
Thank you.
Sure.
Oh, hi, doctor. Will I be on MS medication the rest of my life?
That may be a better question to ask Dr. Aaron when he's up there. Again, I don't treat MS. I've paid for a lot of MS care. I'm not ducking your question, but we have a much more authoritative expert in the back of the room.
Any other questions? Yep, there we go.
Okay, my first thing was an observation. When I was first diagnosed in 2001, I was on a drug and it was like $9,000 a year, which I thought was a lot. And now the cost, if I paid for it myself, would be up to $120,000 a year. So market forces and the number of people with MS really has nothing to do with that. So that's just a personal observation. Second, my question for you is, if the Affordable Care Act is repealed, how would you see that affecting people with MS?
I think the biggest impact, I don't think it's going to change the cost structure of any of these drugs, either to escalate or de-escalate. What it will do is, if the Affordable Care Act is repealed, is there will be a number of people who are getting health insurance coverage through the ACA plans who may not have access to care or to payment for care. That number, we don't know exactly, maybe 20 million people will lose health care coverage if it's appealed. I don't think a rational Congress, now remember I just used the two words juxtaposed, rational and Congress, and I'm not going to get into any political statements. I don't think a rational Congress could look at that and do away with the ACA as we know it. They may modify it, but I think it's unacceptable in one of the most advanced countries in the world that we still have people where health care is not a basic right. That's just my bias.
So you would see it possibly affecting people with pre-existing conditions?
If indeed the pre-existing condition clause were eliminated, yes, you could see the re-emergence of individual coverage plans excluding pre-existing conditions. On the other hand, the people who have developed those plans have actually figured out how to, actuarially account for pre-existing conditions and the like. So they may not. I mean, we just don't know about those things.
Okay, thank you.
Any other questions? Well, if there's no other questions, firstly, I want to thank you all for all of your questions. And then I also want to again thank Dr. Owens. Everyone give him a round.
Thank you.